Hello. So we'll talk about a very important complication seen during regional anesthesia, LAST, local anesthetic systemic toxicity. In this section, I will talk about that why LAST happens, how can we prevent this potentially fatal complication, what are the important precautions we have to take, and how would we identify if LAST is happening in a patient, and how we will manage quickly to prevent the morbidity and mortality in the patient. And we will also talk about a very important management which we do in the LAST, that is the lipid therapy. What is the mechanism of action of lipid therapy and why do we use the lipid therapy and why it is called the rescue drug in LAST. So everything we will discuss. So let us start with LAST. So what is LAST? Local anesthetic systemic toxicity. Now, local anesthetic is the primary drug which we use for regional anesthesia, and it is deposited near the nerve fiber locally. If this drug gets systemically absorbed, then it can go and bind to the sodium channel present elsewhere in the body, as in cardiovascular system, as in central nervous system, and this would result in toxicity. And this is what is local anesthetic systemic toxicity. Now, LAST is always a potential complication for any kind of regional anesthesia. It can happen by any route, even by the topical routes. So we need to be very careful. And the major organs which gets affected, as I just now said, is CNS and CVS. So as I said that LAST is always a potential complication, is always a potential complication of regional anesthesia, potential complication of regional anesthesia, and can occur by any route of administration, and can occur by any route of administration, right? So what is the primary organ getting affected by LAST? So LAST primarily affects CNS and CVS, and this is the reason for its fatality. So it can be potentially fatal. What is the incidence of LAST? Now, as I said, it's always a potential complication, but the incidence of major LAST, that is fatal LAST, is less. And minor clinical features of the LAST are very much underreported. So it is very difficult to comment on the true incidence of LAST. So remember that reported incidence of major LAST, fatal LAST, is low, and the minor clinical features of LAST are very much underreported. Minor clinical features are underreported, right? Okay. So why toxicity? Why does LAST happens? So we all know how does local anesthetic act. We have already discussed in the pharma topic, local anesthetic in detail. That local anesthetic primarily act by binding on the sodium channel. Sodium channel has alpha subunit on its inner membranous side. Local anesthetic binds to it and prevents the influx of the sodium, and this prevents the generation of action potential and propagation of nerve impulse. So we all know that local anesthetic binds to sodium channel, the alpha subunit, right? Present inside the channel, and this prevents the sodium influx, and this prevention of sodium influx, this results in the prevention of action potential generation and propagation of nerve impulse. So this would stop the subsequent depolarization and action potential generation. right? So this is the mode of action of local anesthetic. Now this is the nerve fiber I wanted to block, and we deposited the local anesthetic around this nerve fiber. But we all know that nerve fibers would never be isolated. There would be blood vessels which would be around the nerve fiber. If the drug gets absorbed in these blood vessels, then what can happen? Now toxicity occurs if it gets systemically absorbed, and when the local anesthetic affects the cardiac sodium channel, or the sodium channel present on thalamocortical neurons, or sodium channels present on thalamocortical neuron, right? Thalamocortical neurons. Now this is the primary mode of action on the sodium channel. It blocks the sodium channel. Now local anesthetic can also bind to other channels like potassium channel, calcium channel, NMDA receptor, cholinergic receptor, and also can affect the cellular metabolism, and they may contribute in the toxicity, especially the cardiac toxicity. So local anesthetics can also block the potassium channel, the calcium channel, the NMDA and cholinergic receptor, and it can also affect the cellular metabolic process, and all this will contribute in toxicity. So this can contribute in toxicity, right? So this will contribute in toxicity, remember this. Now different local anesthetic, their potential of causing the toxicity is different. Now why this difference? One thing you need to remember, that all local anesthetic can cause the last, right? Because mode of action of all local anesthetic is same. Then why this difference? What has been seen, the cardiac toxicity is it parallels the potency of local anesthetic. More potent the local anesthetic, more is the risk of cardiac toxicity. So bupivacaine, for example, is a potent local anesthetic which we use for regional anesthesia. Its potential of causing cardiac toxicity is higher compared to other drugs. So how do we compare different local anesthetic for their potential of causing toxicity? So we need to discuss that, right? So local anesthetic all can cause last, right? But there is some difference in the toxicity potential. As I said, that potency parallels the cardiac toxicity. And I explained with the example that bupivacaine, one of the potent LA, is more cardiotoxic compared to other LAs. For comparing the toxicity, we have a way out. There's something called CC-CNS ratio. What is CC-CNS ratio? The CC-CNS ratio is dose at which the cardiovascular collapse can happen with local anesthetic and dose at which it can cause seizure. And higher the CC-CNS ratio, greater is the margin of safety. And it is known by the animal studies that bupivacaine has lowest CC-CNS ratio. So risk of cardiac toxicity is higher with bupivacaine. So as I said, to compare toxicity, we use something called CC-CNS ratio. What is this CC-CNS ratio? The dose at which it will cause cardiovascular collapse and dose at which it will cause seizure. And higher the CC-CNS ratio, greater is the margin of safety. So higher CC-CNS ratio, greater is margin of safety, Now local anesthetic, we have discussed in the topic the regional pharmacology of local anesthetic is divided into two groups, ester and amide. Ester local anesthetic is metabolized by pseudocholinesterase. So any patient on anticholinesterase, the metabolism of ester LA would get affected and the risk of toxicity with Easter LA would increase. That we will discuss later on. So difference in the toxicity, how do we compare? By comparing the CC-CNS ratio. And higher the CC-CNS ratio, greater is the margin of safety, and vice versa. Okay. Now, what is the most common route of or what is the commonest route by which the risk of toxicity is higher? Definitely, it will depend upon the vascularity of the area where we are putting the local anesthetic. But as I said earlier, it can happen by any route. And we need to remember that yes, peripheral nerve blocks have greater potential of causing the lust, but it can also happen on topical application. So never think that you are just using a spray of LA and you can use it multiple times and it will cause no lust. No. Repeated use through the topical route, the risk of lust is always there. So we have to be careful. Studies has been reported last on topical route when repeated dose has been given to the patient. So remember that any route can cause lust. Peripheral nerve blocks more commonly causes lust. This causes more common, right? Lust is more common by through peripheral nerve blocks overall, right? But on topical application also, the lust can happen. Now, topical application on repeated application. So, more risk on repeated application. So, yes, I would compare the routes by which the risk of lust is higher later on in this lecture. But I'm telling it can happen by any route, even by topical application. Keep it in mind and be careful when you are using local anesthetic. Now, there are some important risk factors present in the patient which increases the risk of lust, and we need to give lesser dose of local anesthetic in the patient with these risk factors. So we need to know those risk factors. So what are the risk factors which can increase the incidence of lust? Some patient risk factors. Okay. Now free LA, when it is systemically absorbed, I said that this is the nerve fiber we want to block, and to block it we deposit the LA around it. And if it gets systemically absorbed, right, in the blood, the risk of systemic toxicity is there. So when it is in blood, the LA combines with protein, with the plasma protein, especially alpha-1 acid glycoprotein. So this binds with alpha-1 acid glycoprotein in a larger extent and to some extent to albumin as well. So in case with deficiency of alpha-1 glycoprotein, the free LA in the blood will increase. And this increases the risk of toxicity. So what are the conditions in which alpha-1 glycoprotein can be less in the blood? Extremes of age. So first, age. Now extremes of age, the quantity of alpha-1 acid glycoprotein has been seen less. So extremes of age, that is in infants and old age, right? The alpha-1 acid glycoprotein is decreased. So risk is higher. So what we have to do? We have to give less dose of LA to be used. At extremes of age. So this is the first risk factor, the age, and we need to take precautions. The second would be pregnancy. In pregnancy, the risk of lust is higher due to several reasons. One, in pregnancy, alpha-1 acid glycoprotein and albumin both are decreased. Second, the progesterone hormone increases the sensitivity of nerve fiber to different drugs. So sensitivity of your sodium channel to the local anesthetic would also increase, risk would increase. Then in pregnancy, it's an increased cardiac output condition. So absorption of the drug, systemic absorption would be higher. And in pregnancy, we use the epidural route very commonly for labor analgesia and all. And epidural venous plexus is engorged. So risk of systemic absorption through this route of regional anesthesia is higher than the normal population. And apart from this, the pregnancy, there's pseudocholinesterase enzyme which metabolizes ester LA is decreased. So risk of ester LA toxicity also increases. So in pregnancy, due to several reasons, risk is higher. Risk of last is higher. The first reason I told you, decreased alpha-1 acid glycoprotein and albumin. Decreased alpha-1 acid glycoprotein and albumin. Then number 2, hormone progesterone. Hormone progesterone increases the sensitivity, to LA, right? Sensitivity of nerve fibers to drug. Then it's an increased cardiac output condition, So rapid absorption can happen. The drug can be rapidly absorbed. So rapid absorption can happen. And since in pregnancy we use the neuraxial route very commonly, epidural venous plexus are engorged. So epidural venous engorgement. So this will increase LA, absorption of LA, increase LA absorption from this route. And the fifth is decreased pseudocholinesterase, decreased level of pseudocholinesterase, right? This will also increase the risk of last with ester LA. So these are the risk factors. These are the reason why the risk of last is high in pregnancy. So again, what we have to do? Decrease the dose of LA and be very vigilant on monitoring, okay, when we are using a block in pregnancy. Apart from this, metabolic acidosis, hypoxia, hypercapnia, all would increase the risk of last. And one important, carnitine deficiency increases the risk of cardiac toxicity with bupivacaine. So remember that metabolic acidosis, hypoxia, hypercarbia, all will increase the risk of last. And as I said, carnitine deficiency increases the risk of bupivacaine toxicity, So we have to be very careful if we are giving a regional anesthesia to patient in metabolic acidosis, hypoxia or hypercarbia. Now apart from this, some end organ dysfunction, cardiac dysfunction or hepatic dysfunction, again they increase the incidence of last and we have to decrease the dose of local anesthetic. But remember, renal dysfunction does not increase the risk of last. So end organ dysfunction. So in end organ dysfunction, especially the cardiac and hepatic dysfunction increases risk of last. Now local anesthetic is metabolized. The amide is metabolized by liver. So in case of liver dysfunction, the metabolism of amide LA would be decreased and free LA would be more in the blood. So risk of last would increase. In cardiac dysfunction, the risk of cardiac toxicity is higher because heart is already compromised. And in cardiac dysfunction, alpha-1 acid glycoprotein level is also decreased. So risk of last is increased. But no increase in risk in renal dysfunction. So remember, no increase of risk in renal dysfunction, right? Okay. So these are the different risk factors. Now let us talk about, the block site. What block site would produce higher risk? I already told you, any site can cause last, but the site with a higher vascularity, more would be the risk of last. So in sequence, right? So sites with higher vascularity, increased risk of last. Okay, so highest risk of last has been seen with intercostal block. Intercostal block. Then caudal. Then your lumbar epidural. Then your interfascial block. Interfascial plain block. Right? Especially of abdomen.